All right, welcome back. Let's keep trucking along. Mono is commonly seen in the adolescent population. However, it can also happen in younger children as well. The incubation period after exposure is about 30 to 50 days. That's almost 2 months. That's a long time. So, CROUP is a very broad term for upper airway illnesses that cause swelling of the epiglottis and the larynx. The swelling extends into the trachea and the bronchi. It is characterized by a barking cough that generally gets worse at night. The cause is usually viral. It can be from Hib, it can be from parainfluenza, human metapneumovirus, influenza A or B, adenovirus, or it can also be from measles. Bacterial causes would be it can be caused from pneumonia, pneumococcus, staphylococcus. I guess it would be, yeah. So if anybody has ever had a child or has been around a child who has croup, they know it is kind of a scary thing for parents, even those who are in the medical field, because kids are usually fine during the day and then it gets much worse at night. So with croup, I just mentioned this on the last slide. Kids usually are pretty good during the day. I mean, they don't sound super great, but they don't sound awful either. But as soon as the sun goes down, once 5 o'clock hits and all the doctor's offices and places close, kids start barking and they definitely have some inspiratory stridor. There are two important changes in the upper airway that do occur. The epiglottis swells, thereby occluding the airway, and the trachea swells against the cricoid cartilage, causing some constriction. I think I've kind of hit most everything else. Kids usually have, sore throat, runny nose. They're kind of restless, kind of irritable because, they don't feel good. It's kind of hard for them to breathe a little bit. What are you going to monitor? You better be monitoring the pulse ox, I hope. Anytime somebody comes to you and says they're having difficulty breathing, or you hear wheezing or inspiratory stridor, hopefully this smart nurse in all of you will say, let's put on a pulse ox and see what we're actually satting. Sometimes breathing in cold air helps. Sometimes when my kids have had croup before, at 3 a.m., I've bundled them up in a blanket and we've gone outside and sat on the front porch in the rocking chair and rocked in the cold, October, November air or December air, whatever cold winter month air it was. But the cold air generally helps because, again, if you're breathing in cold, what does that do? It's going to decrease the inflammation. Decrease the inflammation, decrease the swelling, which will decrease the stridor. Croup is going to be treated with a cool mist vaporizer. Sometimes if kids have some serious stridor even at rest, or if they have retractions, they may get a dose of racemic epi. And sometimes kids will have to go on a short-term dose of steroids. They can either be oral, or sometimes kids will just get a steroid shot in the doctor's office too. Epiglottitis. This is something that is a high risk to be on your boards or Kaplan. This is potentially life-threatening because epiglottitis can lead to a complete airway obstruction. You have inflammation of the tissue surrounding the epiglottis. Inflammation in this area can obstruct the airway very quickly. That's why this is such a life-threatening condition. Good news. Since the incidence of the Hib vaccine was introduced, Hib stands for Haemophilus influenza B, there has been a drastic reduction in the cases of epiglottitis. Signs and symptoms, though. Children become suddenly very ill with a high fever of like greater than 102.2. They can go to bed fine and wake up very sick with a very sore throat and pain upon swallowing. There are 4 classic signs of epiglottitis. Okay? Dysphonia, which is a muffled, hoarse, or absent voice sounds. Talking is painful. Dysphagia, which is difficulty swallowing. Drooling, the child refuses to swallow anything due to the throat pain. And distressed respiratory effort with inspiratory stridor. Those are your 4 classic signs. To compensate for the difficulty in breathing, children will assume the tripod position. Look at the picture I put on your slide. See how this kid is kind of leaning forward over his knees? See how he's put his knees down over his legs and he's leaning forward kind of in a tripod position? These kids, they will refuse to lay down. They get very anxious, they get very irritable, they get very restless, they may appear very frightened, and you'd be frightened too if it hurt so bad that you couldn't swallow anything and you were having to drool. Their voice will be thick and muffled, kind of frog-like and croaking sound on inspiration. That sounds like that would be something you should know, like maybe for boards or your exam. Frog-like croaking. Suprasternal and substernal retractions may also be present. So if you are caring for a child and the child has those four cardinal symptoms, or you are just suspecting epiglottitis, this is one of those times when you are not going to look in the mouth because of the laryngospasm / airway obstruction that can occur with any irritation. And those airway muscles at that point in time are going to be so hypersensitive that unless you can intubate them, you better just save it for the people who are going to be there, so that save it for the doctor who can intubate if they need to once they look. When you happen to look in their throat, the throat will be cherry red. That's a good clue. Their epiglottis will be cherry red, swollen upon inspection. You want to postpone anything that will make them cry until their airway is secured so that they don't obstruct it. Are you going to go in there and tell them that they're going to have to stay all night? Are you going to tell them any kind of bad news in front of the child, like the parents? Are you going to tell them anything that might upset the child in front of the child? No. You're going to call them out of the room and tell them. Good news is usually the swelling will decrease within 24 hours of antibiotic therapy. Racemic epi and steroids may be helpful if it's done early on. Children will need a 7 to 10 day course of antibiotics. Anyone younger than 4 years who has had contact with the infected child will get 4 days of rifampin. All right, so let's talk a little bit about bronchitis. Symptoms of bronchitis include a dry, hacking cough that is worse at night and may or may not be productive. Oftentimes people will complain about pain in the chest and the ribs due to the frequent and deep coughing. Breath sounds can become coarse with fine crackles scattered with high-pitched wheezing. Treatment: provide comfort care unless a secondary infection requires antibiotics. Treatment is usually just rest, humidification, hydration, cough suppressants. Sometimes we do give steroids. I'm not going to lie. Sometimes the kids will get a short course of steroids. RSV presents itself as a cold to older kids and adults, and you never know if it's just a cold or if it's really RSV. The peak incidence is between October through April generally. Kids at risk for RSV include babies who are less than, sorry, I was trying to cover up my yawn. Kids at risk for RSV include babies who are less than 2 years old with chronic lung disease, those who are immunosuppressed, babies born less than 35 weeks gestation, so takes into account some of your NICU kids, and kids with congenital heart disease or any kind of severe neuromuscular disease. Nearly all children will have had RSV by the time they're 3 years old. So it's not like it only affects certain people. It's a pretty common thing. The pathophysiology is kind of cool. Viruses invade the mucosal cells that line the bronchi and the bronchioles. Those cells die when the virus bursts out of the cell to invade the neighbor cells. The membranes of those dead cells fuse and they create large masses of cells or they just junk up the lungs basically. Those dead cells clog up the bronchioles and they irritate the airway, so the airway responds with edema and excessive mucus. This results in a partial airway obstruction and bronchospasms. The virus is shed by the infected child for 3 to 8 days, and others acquire it by contact with respiratory secretions or contaminated surfaces. So, if you think about RSV, it's kind of like a terrorist who invades your home and then blows it up and then moves on to your neighbor's house. Eventually, the whole neighborhood is blown up and there is a mess to clean up. That's RSV. On X-ray, RSV shows up as hyperinflation, some patchy atelectasis. These children often, they just don't feel well and they're not going to eat well. so they may need IV fluids to prevent them from becoming dehydrated. Steroids generally will not help, but bronchodilators will. So these kids will get breathing treatments. Synagis can be given every 28 days. Again, we talked about this before. Coverage is cumulative and it's expensive. $6,000 per shot. And you have to have a shot every 28 days. It's an immunoglobulin, so it won't prevent you from getting it, but it will lessen the severity if you do get it. Because it's so expensive, again, it's made from unicorn tears. It is recommended only for high-risk infants. Okay, so for lower airway pneumonia, I want you to see page 1213 in your book for a list of the common culprits. Viral pneumonia occurs more frequently than bacterial, which is kind of a good thing, and occurs usually secondary to an upper respiratory infection. It can be caused from RSV, parainfluenza, enterovirus, adenovirus, influenza, blah, blah, blah. Viruses basically enter via the respiratory tract, they invade the alveoli, they replicate, they burst out of the cells, kills them, clogs up the lungs with all the cellular debris and mucus. Very, very similar to RSV. Bacterial invaders, bacteria basically circulate through the bloodstream to the lungs where they damage the cells, they cause inflammation and edema. All that cellular debris and mucus clogs up the lungs. Again, pneumonia is going to be diagnosed by a chest x-ray. You're also going to look at the CBC. White count usually goes up to greater than 20,000. Treatment is going to be airway management, fluids, rest, antibiotics, O2 therapy as needed, antipyretics to treat the fever, help kids, feel better too. Sometimes chest tubes may be needed if there is a lot of purulent drainage in the lungs. CPT can be done to help break up those lung secretions. Your book talks about pertussis and TB in children. Feel free to read the small section on that as well. All right, foreign body aspiration. This is a common cause of unintentional injury in children in the home setting. The right lung is more common to have foreign body aspiration because of the sloped angle of its bronchus. So these x-rays you can see show a child who has aspirated a screw and the other child has aspirated a coin. Looks to be like a quarter because it looks pretty large. Clinical manifestations, dysphonia. Muffled or hoarse voice sounds are a clue that a child has aspirated something that they should not have. Dyspnea, again, difficulty breathing. Obviously the choking, gagging, spasmodic coughing, things like that. If you suspect that a child has aspirated a foreign body, if they're able, ask them to say P words like pancake or Peter Pan. If they cannot say words that start with P, like pencil, pepperoni, pancake, Peter Pan, then they have diminished expiratory effort. Obviously, the treatment for foreign body aspiration is going to be the removal of said foreign body. It can be done with forceps if it's above the larynx. Otherwise, the child's going to have to be taken to the OR. Again, this is an opportunity for some parent teaching. Although even good and smart parents have children who sometimes make bad choices and aspirate things. So, just because a child has aspirated something doesn't mean the parents suck. It doesn't mean the parents aren't watching their kids. It happens. From personal experience, I'll just tell you, it can happen.